Hello, everyone. Good morning, good afternoon, good evening, wherever you may be. Welcome to this very special webinar organized by the EAU Patient Office together with WFIPP, the World Federation for Incontinence and Pelvic Problems. I'm the president of the WFIPP, and I have the privilege and the honor of moderating this session on shared decision-making in the management of incontinence. We only have 1 hour, but we would hope that the 1 hour will give you some insights from the speakers. We have a great lineup of speakers whom I will introduce right now. We have Jenny Ghith from Pfizer. She's the Senior Director, Strategy and Innovation Lead in Pfizer Oncology, and she will be focusing on AI and innovative therapies and technologies, and see how that can be brought into the patient centricity context. So that's Jenny. Then we have Jim Phillips. He's the Director of the Centre for Empowering Patients and Communities, a UK-based organisation working very closely with the NHS in the UK. He has over 20 years of experience in the field and is very much into patient empowerment, and I'm sure he has a lot of expertise that he can share with us. Then we have Michiel van Balken, who is a leading urologist in the Netherlands from functional urology, which deals with aspects such as the dedicated to incontinence and chronic pelvic pain and so on. He's a board member of the EAU Patient Office and the working group, and he has many accolades and done an awful lot, Michiel. And so they're the three speakers. What we will do is, after each presentation, which will last 15 minutes, we will have one question per speaker, and then at the end, hopefully time will allow to have an interactive session of 10 minutes for everybody. Now, a few technical points, household points. First of all, the webinar is recorded and will be available within 48 hours on the EAU and the UROwebinar YouTube channel. That's one thing. Secondly, within 48 hours, you will receive a mail or whatever it may be to answer 3 multiple choice questions per speaker to get the accreditation, which is available if you answer correctly or otherwise, presumably. And as I say, we've only got 1 hour, so I'm not going to say very much more myself, except that we stick to time, and hopefully, as I say, by the end of the 1 hour, we'll have a lot more knowledge and insights. So Jenny, if I may, over to you. Thank you.
Thank you, Lynn. Hi, everyone. I'm Jenny, and I'd like to open with a quote that seems very timely, given our situation these days and the really expansion of technology. So this is from a gentleman at Google. So there were 5 exabytes of information created between the dawn of civilization through 2003, but now that much information is created every 2 days. And this is a situation that we're faced with to help arrive at the best outcomes for patients. And it is an enormous responsibility for clinicians and the healthcare community and patients to stay up to date in the face of so much information. This is my disclosure. So why are we here? When we think about shared decision-making and the potential it has for improved outcomes, we have clinicians and the healthcare community who are relying on clinical expertise and context. They're assessing the evidence. Based on their training, they're assessing risks and benefits for their patients. They're analyzing test results. They're addressing biases or being aware of them as they go through data, and they're up against time. And then we have patients who have goals, values, preferences, and their families and their caregivers. And we want to come to a place where we're arriving at a collaborative plan amongst physicians and patients in order to drive the best outcomes. But what's not in the graphic here is what else is happening in terms of other influences that are affecting healthcare. We all have access to the internet, or many of us do, although not all of us, and that is a challenge. We're going to talk about artificial intelligence and how that is changing the landscape of information as well. And we're facing misinformation. These models that we use, particularly with artificial intelligence, don't necessarily know what the right answer is or what the truth is. What they're doing is they're using technology to predict the outcome based on the model. They're knowledge models. They're language models. They're not knowledge models. And on top of that, we have social media. We have more data than ever, as I already mentioned, and we have enormous pressures on the healthcare systems themselves, as well as privacy and security needs to deal with. There's a definition here of shared decision-making, and it's a joint process in which a professional works together with a person or a patient to reach a decision about their care, about their diagnosis and their treatment plan. And it involves choosing tests and treatments based on the evidence and on individual preferences, beliefs, and their values. And this is from the Council of Europe portal, which is a UK-based definition, but it resonates across the globe. And the benefits of shared decision-making are well documented. We see improved well-being, quality of life, better adaptation to the long-term effects of treatments, greater independence, and more sustainable healthcare systems. But again, contributing to this situation is that physicians are facing burnout. It's difficult to keep up with the information landscape. It's difficult for patients too, who are coming to offices using Dr. Google, for example. But there is, again, a lot of questions about the information that is out there on the internet. Diagnoses, treatments, and trials themselves are increasingly complex. Patients are facing difficulties in getting care, and then misinformation is a major concern associated with all of this. So the question is, where is technology now, and how might it change our interactions? How might it actually help us? And you may be an optimist about technology and about things like artificial intelligence. You may have trepidation. You may be more of a pessimist and have concerns about things like privacy, about responsible use of AI and explainability. But perhaps somewhere in the middle is a more practical understanding of the situation and an understanding of how we can use the right tool to address the right question. So there are two examples on the slide, and I could have put, 102. But what I thought we'd do is we just illustrate the range of possibility with the technology. So you're going to see this in your day-to-day. It's here, whether you really are prepared for it or not. In fact, it's probably already in your day-to-day if you're using web search portals, or if you are using things like Netflix. Those have AI algorithms in the background. But if you think about how it might help, we search for information, we try to stay abreast of the literature, and we have developed tools that help us pull out the most relevant articles based on the scientific question that we have. And this is one example of one of those tools. We called it Project Inside. And all that does is pull the right references for the right subject matter expert to help them read and answer the information. But there's really a spectrum of tools available. What's not on the slide is the great work that the EAU is doing, that other societies are doing to provide educational materials on the web. And then the other end of the spectrum is really multimodal AI and co-pilots. So what that means is that the AI is taking in multiple different types of inputs. It's not just the text, it's the pictures, it's the video, it's the audio, it's the notes that patients are helping with or the physicians are taking during the office visits. It's the radiology reports. And multimodal AI is going to take us to a place where all of that medical knowledge can contribute to help us answer questions of scientific interest and also address patient needs. And again, this is also going to appear in your day-to-day activities, even as a general consumer, because companies like Microsoft are embedding AI into their Office 365, into the tools that you use on your computers every day. So it can be overwhelming. And the other question is, well, can it help and how should it help? And there has been some literature where we're starting to look at empathy in these models. Again, these are language models. They're not knowledge models, but they write very well. They're very clear. And there was a study that came out from UCSD where they looked at responses on social media, and they had AI-generated responses and human-generated responses. And licensed healthcare professionals actually preferred the AI-generated responses, and they rated them as highly empathetic. Now, the challenge with this is it doesn't replace a doctor visit or the dialogue that needs to happen with shared decision-making, but nonetheless, it's interesting. And the question becomes, how can these tools help? And what mechanisms do we need to put into place to make sure that they don't harm? So there are benefits and risks, and other tools are coming. This is GPT-4 Vision. We're going to see systems that can read or interpret images and expressions that humans make, and then predict what you might see in the next image, for instance. So all this is very exciting. But if you're overwhelmed, you're not alone. And your foundational needs and practices as scientists and as clinicians, and what you need as a patient, all that still applies. And you're going to have to use these tools and optimize them to help each other through the shared decision-making process, and stay true to all the values and the foundational components of shared decision-making. So in summary, whether you're optimist or a pessimist or somewhere in between as a practicalist, I think it's really important that we educate ourselves and we upskill and we engage in cross-disciplinary dialogue, and we think about where the technology can help, as well as some of the consequences if it's misused. So it can help with patient engagement. We see evidence that it can help with literacy. These systems can do translations and summarize notes and do some of the more routine tasks in the clinic. And they can help patients find ways to communicate their preferences to their physicians. It can help us overcome time barriers. This is tough when clinicians are seeing over 40 patients a week sometimes, maybe more, and help us address information overload. And hopefully facilitate new ways for us to interact with our teams, and democratize data, make it easier for us all to understand and learn from the data. But if these technologies are misused, we risk inaccuracies and biases. We risk more misinterpretation and misinformation than we already see, and our privacy and security may be violated. So again, it's really important that we upskill and we work to understand the technology, and that we all have a seat at the table in the discussions with the developers, with the regulators, with the clinicians, and the healthcare systems that are using these tools. So with that, Lynn, I'll turn it back over to you.
Thank you very much, Jenny. Very illuminating and a lot to take in. I just have one question for you, if I may. How do you think all of us here, and I've just been looking through the chat to see that we've got people from just about everywhere, how do you think we can stay abreast and up to scratch with these new technologies? And what does it mean when it comes to shared decision making? Quick answer.
Yeah, thanks, Lynn. It's a very important question. Everything is moving so fast with the technology. So you're going to have to go to sources that you may not have gone to in the past. You may need to look at social media just to understand the pulse or the sentiment around technology, because a lot of the developers post there. You may need to look at preprints. You may need to go to technology meetings that you may not have gone to before. And you also need to keep abreast of the general literature and the general public sentiment around the technology as well. And all of this, I think the hope is that this is one tool, that these technologies are tools that can help with shared decision making. It's one piece of a toolbox that includes other things that a patient and a physician can use to help increase the dialogue between them.
Great, thank you so much, Jenny. And I would also say, if anyone's got any questions, please put them in the chat, and even if we don't have time today to answer them, they will be answered in due course, so please go ahead. Now we're going to turn to Michiel from Balken. Michiel, I know, is passionate about shared decision making and about health literacy, and working very much not talking to patients, but talking with patients. So with that, Michiel, I hand over to you. Thank you.
Thank you so much. My talk will be on how, as urologists, do we make sure that we can have a good shared decision making? How can we facilitate data on which patients can decide? And this is not that easy. You might ask yourself, is there a problem? Patients can easily find the information they want, and they read it at home and make proper decisions accordingly. But there are several problems with this statement. First, there is quite a lot of information, but not in every language. English is the main language, and a lot of information also that is created by, for example, the European Association of Urology is created in English and is not always available in one of the many languages that are already there, for example, in Europe. This is a problem because not every country is rich enough to make their own information in the right way, or even going to translate it in the right way. So there might be difficulties in getting the information in your language. But even if you can get information in your language, there might be slight differences in how you interpret it. Some words, even in the small country of the Netherlands, words used in the Western part might be a little harsh, a little bit vulgar when spoken in the southern part of the Netherlands. So language and languages are one thing that might hamper good use of information and the distribution of information. Besides that, a lot of patients are not able to read or write very properly, even in a well-educated country as the Netherlands. Over 2 million people out of 17 million people are not able to read or write very well. Not that they cannot read at all, but they have difficulties. And so you can understand that relying on information that is mostly written is some kind of a challenge. And this gives problems on all aspects in daily life, but it's also in care. And when we use the difficulties of getting information, interpreting information on your health, and making sure that you can use information to do the right things, then we call it health literacy. And in the tables, at the table below, you can see for some European countries, Austria at the top, Bulgaria below, and then Germany, and NL is, for example, the Netherlands. And you can see that there is some difference in health literacy percentages over Europe. So there is quite a problem. These are huge numbers. With problems with reading and with problems of using information for your health literacy, comes all kinds of other problems, like problems with calculation, but also digital problems. And by that, we mean that there are difficulties using, for example, computers or the internet. But also you have to have access to the internet, which is not always there in different parts of Europe. Quite astonishing. People who never access the internet in 2021, mind you, might go up to a quarter of the population in some parts of Europe. Never access the internet at all. So there might be some problems. if we really want patients to participate in shared decision making, we not only have to make sure that there's information that is based on language and on the level of language that can easily be accessed, but it also has to be reliable and trustworthy. Not very strangely, as I am part of the EU Patient Office and the Patient Information Working Group, I wholeheartedly would like to point you at the EU Patient Information, because it covers many aspects of urological problems, also on all kinds of aspects of the incontinence problems, but it also shares it in several languages from all over Europe, and even in languages that are from outside Europe, Arab and Chinese, for example. But there are also other websites like the ones from the WFIPP or national websites that are based on trustworthy and reliable information, and that are from patient groups and patient advocate groups that have their own aspects on problems like the influence on your daily life, etc. So reliable information is also very important. If we really want patients to participate in shared decision making, we have to make sure that decision aids, the tool we think is very helpful in helping to do shared decision making, that the decision aids are reliable and easily accessible. And there are some problems with that. There's a Dutch graph. If you cannot understand it, then you'll immediately have an illustration on how difficult another language can be for you. But this diagram shows for 13 Dutch language decision aids on urology, how difficult the language was used in this decision aid. And the top line, not the dots with the straight line, shows that all the 13 decision aids were in the gray area, and the top graph shows that when you have a high level high school education, then you only understand 70% of the information that is on the decision aid. And when you have a low education, that you only understand about 38% of what's in the decision aid. And now you can say, yes, that is for the Dutch population, or yeah, that is for Dutch decision aids. But I think that is not just for Dutch urological decision aids. There are different other aspects of decision aids that make them sharing it and relying on it a little bit difficult. Decision aids are very popular, but they are very popular for some companies who want to make money out of it. And there's the risk of creating decision aids on some popular items within urology or other disciplines. For example, there might be a lot of decision aids on prostate cancer, but not so much on less popular aspects like overactive bladder or painful bladder syndrome, for example. Because it takes some time to develop, and because it's nice to have a commercial aspect, most of the decision aids are behind paywalls. We think that the decision aid should be freely accessible for patients, or they are heavily advertised, and there are only so many languages that have validated decision aids. Most decision aids have you choose between 2 different or 3 different kind of treatments, but there's hardly in it that you can also do nothing. And for doctors, we have to be a little bit careful, as there might be some liability issues with the use of decision aids. If you ask for data, in the last couple of minutes we were talking about giving information, but shared decision is also about making your decisions on the data you get from the patient instead of the information that you give to the patient. And when we ask for data, we have to make sure that the things doctors want to know are really understood by patients. And it might be very difficult. You see it illustrated IPSS. The IPSS score is an international prostate symptom score, a score that urologists use a lot in mainly men patients with voiding problems. It's a very difficult one to fill out, and you can use illustrations to make these IPSS a little bit more easy to understand. But if you go to a much more difficult a questionnaire like the micturition diary or avoiding diary, by which many aspects of how you pee on what time and how much and if you leak, etc., have to be filled out, then these illustrations do not work very well. And it often goes very wrong, as you can see on examples above the micturition diary. But here you can use spoken animations, which are also very effective in delivering information to patients. But you can use spoken information as an instruction, as we are investigating now in our clinics. And on the other side of the slide, completely on the opposite from the quote, you see two small pictures above each other. It is now even possible to make sure that the questionnaire itself can be an animation. So you see an animation going on, and that at some time the animation stops. A question is asked, and then you can tap the animation, the right answer, and then the animation goes on. So the questionnaire itself is animated. As animations and spoken animations are very useful in delivering information, we know that. There's a lot of research that tells us that when you are not good in reading, you're not good at writing, that if you have a spoken information, then the message is getting to you very well, as good as to someone who can read and write very well. Spoken animations are very easy in using to give information as it is to get some information from patients. Also, if you want data from patients to enable shared decision making for the future, then there's the issue of PROMs and PREMs, but that will be discussed by the next speaker. Shortly, of course, it was mentioned by the last speaker that artificial intelligence might be of some help. For now, the artificial intelligence that most people think about is the thing like ChatGPT, although there are new players on the market like Google Bard and Bing Chat. And now we have artificial intelligence, then maybe these chatbots can solve our problems regarding shared decision making. For example, in explaining things, you can ask ChatGPT, pretend I am a 6-year-old, and could you explain to me what the doctor means by mixed incontinence, mainly OAB? And it rather well gives some explanation in easy language to tell you what is the case. You can also check some more difficult questions, but it's not that reliable that you can completely rely on these chat boxes. We did a small research in Dutch urology. We tested the 3 chat boxes with the urological knowledge that is needed to become a urologist. And we checked some guideline questions that the Dutch urologists answer twice a week to maintain their knowledge. So over 500 questions. And for now, these artificial intelligence chat boxes like ChatGPT are as good as a mediocre urologist. But things are going very fast. And we know that the way you ask your questions are also very important. So it might be that things change very quickly. So in short, if we want to make sure that we can really participate in and facilitate shared decision making, we have to make sure that the information is easily accessible to all. Also in other languages, also for those who cannot read and write very well. Animations might be very handy in delivering the information as well as in asking for information that we can rely on together. And maybe there's some extra help in future in the near future for artificial intelligence. But as a doctor, we have to make sure that also if we rely on these things, that this is also trustworthy as well. Thank you so much. Back to you, Lynn.
Thank you very much, Michiel. And in fact, I share your views about the health literacy aspect, that this is key. And of course, with 27 member nations in the EU alone, and then we go beyond that, it really is extremely complex as to how we get the information across. Having said that, to what extent do you think that shared decision-making can or will make an impact on the doctor-patient relationship? And does everyone want that? It is a very loaded question, I know, and quick answer.
Not everybody wants it, so you have to be, as a doctor, you have to make sure that the patient that wants the doctor to decide what's going on, because it does not want to do it by itself, doesn't want to take this responsibility. It has to. It means that you, as a doctor, still have some responsibility, or a huge responsibility, in explaining why you do take some decisions, but. Not every patient want to be part of a real shared decision-making process. Doctors have to be convinced that the time that they put in, the extra time that they put in the shared decision-making process in the beginning will lead to less time in the future, because it's one of the arguments against a lot of these projects, but many doctors started their education and studies because they wanted to help patients. And if patients really get a chance to tell doctors what they want and what is important for them, and they can decide accordingly, more patients will be happy, and so the doctor will have made more patients, was able to help more patients the way he already wanted when he started this education. So I think it will change for the good.
Yes, thank you very much. Food for thought, and obviously we can't give a very long answer here, but there are some questions in the chat which we will have some time, I think, at the end that they will be answered. I'm going to move now to Jim. And Jim, I had the honor, if you like, of listening to you last month. Last month, it was September, your webinar, and hence I was really impressed with what you had to say about preparing patients for this idea of shared decision-making. So please, can you illuminate a little more? Thank you.
Certainly. Thank you ever so much for this opportunity to talk to you about what is such an important topic. I'm going to look at the role of a patient in shared decision-making, but also in a way, hopefully through these slides, outline why we need to use patient-reported outcome measures and patient-reported experience measures far more in our work as well, to really understand to what extent the shared decision-making process is actually functioning well, and that the patient's experience and outcomes really are being improved through it. So I'm going to sort of go through a number of points. So, you know, there's quite often a fundamental difference in perspectives between the patient and the clinician. And this is a little cartoon of you know, one person on a desert island seeing a boat going, "Hey, boat, I'm saved," and the other person in a boat adrift going, "Land, I'm saved." Neither of which, though, will get the outcome that they were hoping for. And we also know that both clinicians and patients routinely overestimate benefit and underestimated unwanted outcomes. And as patients, we instinctively filter information as well, depending on our preferences and bias. We might purely hear the negatives, or we might purely hear the positives. So high quality information is absolutely essential, as highlighted by the previous speakers, but also the way we communicated and our communication skills and our ability to check out people's understanding is absolutely essential in this process at all. Because what we think we've said is not the same as what people hear. And we also know that what's important varies as well. So therefore, understanding patients' preferences and their experiences. So here's a study done into top goals and concerns around breast cancer decisions. So patients, so this was based on interviews with patients and clinicians. And as we can see, there's quite a fundamental difference in what's considered the most important outcome and what's important to people in the decision making. And we're talking about this particularly within the NHS in England, and where we see shared decision making as fundamental in the use of decision support tools. It's really creating the shift of people feeling much more empowered, the shift away from feeling done to and becoming active partners. And we know this is important in terms of patient outcomes and everything, because we know that when people work in partnership and feel that they're involved in decision about their care, the levels of treatment regret are far lower, and also adherence towards treatment regimes, particularly some which might be quite difficult and punishing, are significantly higher as well in these situations. This is a similar slide that Jenny had earlier, but sort of key to this process is the clinician holds the knowledge around the options, the benefits, the harms, the consequences, the treatment burden, and this sort of thing. Whilst the patient understands their own circumstances, their values, their preferences, what for them is a good outcome, what's most important to them around an outcome, around how it's going to impact on their ability to work, their ability to have a social life, to what extent they still feel able to participate in public as well, particularly with certain conditions. So all of that comes into play within that conversation, within that negotiation between the clinician and the patient. So what we hope we end up with is a decision that accords with both the evidence of what's most effective, but also in terms of personal circumstances as well. And as the other speakers have said, you know, this includes doing nothing and not taking any action at all. And that needs to be given equal importance. So what we also know is, as was mentioned earlier, that when it's done poorly, there's a cost attached to this. We know that there's more likely to be harm. We know there's more likely to be treatment regret. We know there's more likely to be low adherence to agreed course of action. Within the NHS, we see higher levels of things like litigation. And we're seeing quite a few areas where the decision making has been poor quality and hasn't been shared. There's quite a high level of people who would have preferred to take a different course of action if they'd have been better informed in the first place. So it does have consequences. So within these conversations, we need to ensure that all elements of the biopsychosocial model are being covered off, not just the biological in terms of medication, treatment, and adherence, but also really eliciting the patient's beliefs and preferences, understanding their level of health literacy, understanding their life narrative, and a whole other issues which are going to impact on the way we're going to participate in the decision making. And we also know that, I mean, this is incredibly generalized, but clinical interventions make up around 25% of health outcomes. I mean, no issues such as health inequalities and everything else actually have a hugely significant impact as well. Now, quite often as a clinician, you might think, well, this other stuff isn't any business of mine. This is about wider society issues, sort of unemployment and this sort of thing. I know it impacts on people's health, but understanding that, it helps understand what the patient's motivation is around what's going on, and we're going to get much more meaningful outcomes as well. So we need to look at the skills here so that we have the skills to raise the patient's awareness of the current situation, really exploring what matters to them. We know that in studies we find that clinicians are quite poor sometimes at eliciting patients' beliefs and preferences. There's a tendency to interrupt before it's been fully explored. So there's a whole set of skills here. And one of the reasons we set up the Personalised Care Institute within the NHS was to ensure that there's access to these skills. We also need to recognise that people have to have the capability and confidence to take part in this, and the right support needs to be in place as well. And also that information is provided in a timely way. And I use a good example of this. My mother, who had terminal lung cancer, had to go in to have a potential chest drain. The clinician wanted to insert a permanent drain there. She wasn't aware that this was going to be part of the discussion. She thought this was going to be a temporary thing. So she was unable to go ahead with that procedure because she didn't feel emotionally prepared or ready for it. So thinking around how we provide information prior to a consultation where a decision is going to be made is really, really important. But it's not just about sending out that information early, but it's then thinking through, does that person have the right support in place to think through the consequences of those decisions so that they become far more prepared. And we know through the European health literacy surveys that around 30% of people won't have the right level of competence, knowledge or skills to manage their health condition or have the levels of health literacy to participate in a shared decision-making way. So however high quality the information is, we've really got to think through the timing of when we provide this information, ensuring that people have time to start making those emotional adjustments around what the consequences of that decision might be, and also then ensuring that we give the time to really explore the pros and cons of each potential treatment or surgical option as well, what might be available. So this is quite tricky and this is quite complex. And there's a big question here around how do we know that this is happening? So I'm just going to flick back. So we use the GP and hospital survey questionnaires across the NHS. So we routinely ask the question, to what extent do you feel involved in decisions? About 40% of patients don't feel fully involved in decisions about their care. And what's worrying is a percentage of people who don't feel they've got enough support to manage their health and well-being as well. And these figures haven't changed since 2018. And in actual fact, they've got worse. They've stayed the same or actually deteriorated in some cases as well. So this shows that despite the overarching belief that we are involving people in decisions, the patient experience is very different. So just going back, so we really need to think around how we implement shared decision making and how we are actually evaluating to what extent we are involving people. So we need to think about how do we train our clinical teams to have the advanced communication skills and the ability to actually communicate quite sometimes complex information and issues such as absolute risk and relative risk as well, and also elicit the patient's own sort of beliefs and preferences as well. We need to think through very carefully, how do we actually prepare people and ensure that they've got the confidence, and the capability to take part in shared decision making as well. And then we've got to think, therefore, how the system operates. How do we communicate test results? How do we communicate information? And how do we do all of this in a timely way, an appropriate way, so that we don't overwhelm the patient, and we give them the chance to think it through and make the necessary emotional adjustments as well. We can put in place lots and lots of policy and everything else, and we have done that within the NHS, but we need to think it through in terms of our teams and our organisations to drive this change through. And then we need to think really, really carefully how we're going to use sort of a patient generated data to really assess to what extent we are meeting patients' preferences. So the use of patient-reported outcome measures, and there's a huge range of them, and I'm not even going to begin to sort of touch on what might be appropriate for your specialist fields, but also patient-reported experience measures as well. And we need to do the two together. Are patients getting the outcomes that they want, where it's possible, but also is their experience of the process how we want it to be as well. So, and that can really help sort of help mitigate our own sort of biases and beliefs around our own sort of skill levels in this area as well. Because we know when we do observed studies, there's a mismatch between the clinician's belief around the skills in shared decision making and the patient experience. And this is why we really need to sort of routinely use PREMS within this area as well. And I mentioned the Personalised Care Institute. There's a whole range of training resources there around shared decision making, including the use of sort of avatars and this sort of thing as well. We've done a lot of work around developing the core competencies needed for the workforce around this, but also investing quite heavily in decision support tools, which our previous speaker sort of spoke about as well. And we really need to keep in our minds all the time levels around health literacy. Because don't forget, for the patient, this is something new. As a clinician, you've had 20, 30 years training in your specialist area. For the patient, they've had their diagnosis. They maybe had weeks to sort of get used to it. They don't have the knowledge or anything. So we've really got to think around how we support them through that process, and think around the wider workforce, such as health and wellbeing coaches and wider support around the wider determinants of health through what we've got in England, things like social prescribing and other things as well. And I believe that takes us neatly up to time to leave the last sort of 10 minutes for questions and further points. Thank you.
Thank you very much, Jim. In fact, I've got quite a lot of things that I've been writing down there, but I've got one question for you. To what extent do you think the shared decision making, and we have to be very careful with the use of this term because it's bandied around just about everywhere. What do we actually mean by it? To what extent do you think it's already being practiced? And is that at primary level, secondary level, or what? Just a quick thought on that one.
We just know that is not being practiced as well as it could be. We know that from the things like the GP survey, the hospital survey, that 40% of patients don't feel fully involved. And we know, as I was saying, there's significant mismatch between clinicians' perceived skills around this and the patient's experience of it as well. We see shared decision making as a fundamental gateway, not just into making a choice about treatment, but also things into sort of access into self-management support and health education and this side of things as well, because it's not only making a treatment about a decision, but for many patients it will involve significant changes to the lifestyle, what they can eat, how they can socialize, how they can work and everything else. So we need to consider that side of it alongside, and that is often poorly covered as well within shared decision making. So I think there's a belief a lot of shared decision making is happening, but I think the patient experience is often very different.
Okay, thank you. By the way, we've put in the chat the link to your website, so that I do recommend that people do go and have a look, because there's an awful lot of information there. I'll get back to the couple of questions now that were asked. Thank you for your patience. We have a question here which says, we all agree the shared decision making is good for patients. How can we support an understanding that SDM is also good for healthcare professionals? Michael, I'll go to you first.
I was afraid so. Yeah, well, doctors know. They know that the happy patient is the way to go. The unhappy patient is not only not happy, but also coming back all the time. Doctors know that patients need to be listened to more. It's not the fact that this is not the case. It's more that a lot of practical things are hampering the time and the efforts they can put into this process, because the way you can offer good shared decision making often means that you have to put some time in it. We can make sure, we can try to convince the doctors that the fact that they put this time in it in the beginning will pay out in the end. But that still is something that is quite a little bit difficult. And we can help them make their lives a little bit easier by not having doctors create all kinds of instruments to facilitate this shared decision making, but also have technology and other parties having organizing and creating stuff that helps the shared decision making. And this is a slight point referring to the last talk of this webinar. The prompts and prems might be very useful items in seeing what we are doing and finding what patients really feel is important. But most of these prompts and prems up till now are created by doctors that that put in it things that they feel is very important. So if you're going to use prompts and prems in the future to help creating more understanding and to try to find out what is really important for patients, then we have patients to help creating these prompts and prems.
Mm-hmm. Jenny, perhaps your take on it, because I can see you nodding, so perhaps.
Well, so I think I agree with everything Michael has said. I think sometimes we forget how challenging it is right now, how many patients doctors are seeing and some of the challenges that they're facing. So we've spoken with some physicians and done some surveys and things, and you know, it's difficult to even switch off your brain between visits, is what some physicians tell us, that you're running from one diagnosis into a room directly to another person, right? So that the physicians are people too. And I think that they are under enormous strain and they're facing challenges with administrative burdens as well. So if there are innovative ways to help them and to remove some of those administrative burden activities through new technologies, I think that is a way that could help. So if your information is summarized, if your patient notes are summarized more quickly for you, if some of those other tasks become easier, perhaps that will leave more time for physicians to process information in their own minds. And patients have only a few minutes with their doctors, and they're looking for a decision and an answer. And sometimes you need to pause and think through what is happening next, and whether there's an opportunity to have a follow-up visit of some kind may also be an option as well. So there are a lot of things that could be done to help, but I think in the end, we are victims of our own riches. We have so many things at our disposal now. It becomes a question of choosing the right things that are going to be used.
Yes, thank you. I totally agree. I think sometimes we're bombarded with all the data and all the various issues, and it's very difficult both for clinicians, allied professionals, and the patients to minimize this mismatch that you were talking about, Jim. Jim, I have a question directly for you, which says, are our healthcare systems as currently structured ready to implement and facilitate shared decision-making? That's a big one.
The simple answer is no. As Jenny's just alluded to, sort of people are rushing from clinic to clinic, or outpatient clinics are designed in a particular way to create a certain flow through, so you don't necessarily have the time to, where you've got a patient with low health literacy, to put the time into whether that's needed. We're not using people with lived experience enough, as Mikael was saying, to design prems and proms either. And there's something around how we share test results and everything else. You know, quite often you turn up at a clinic, you're given your results there, you're talk through the implementations all within sort of 10 minutes. So there isn't a reflection time. So we talk about prepared patients, as I've been talking about. We talk about trained teams who've got the skills, but we also talk about supportive systems. And I think that's a key piece which is now often missing. So we need to think through, how do we sort of change the way some of our clinics work, how we make greater use of things like group consultations, for example, because that brings in the peer support element as well. And we need to think much more around how we use technology so that people have information in a timely way and then are supported. So in the NHS, we now employ care coordinators specifically who can spend an hour with a patient sort of talking through the pros and cons of various things, so helping them to prepare for major sort of decisions about sort of surgery and this sort of thing as well. So it takes some of the pressure off the clinician. So yeah, we've got quite a long way to go yet, I think, to really sort of begin to shift our systems.
If there was just one point, one aspect in 1 minute just before we wrap up, Jenny, what would you recommend to all the people who are listening to this webinar now and who will watch it later on? What would you say to them? What can they do? Perhaps even if it's just one thing, what would be your prime recommendation?
Bit of a soft one. It's continue to focus on empathy and challenge your own assumptions as clinicians and as patients. You only have a few minutes, and there's so much going on around you in those offices, and it's important to try to think about that and to work collaboratively together.
Jim, same question.
I would completely agree with what Jenny's just said, actually. Talk to people, ask. Don't be afraid of asking the difficult question.
Yeah, and additionally, a lot of time and effort and energy can be saved if not every doctor or every organization is doing its own work. Use these centered opportunities like, for example, the EU patient office, but it might be other things that offer concentrated, well-organized information and tools that you do not have to find out all by yourself. Use these instruments and have tried to translate it or something like that. But if every effort, there's so much energy, even by doctors who are very passionate about things, but if every doctor is doing it by himself, then it costs much more energy than is needed. Yeah. Work together, collaborate, as Jim said. Yeah,
I would say exactly the same from our point of view, from the patient advocacy point of view. Work together, collaborate, make sure that you align the work that you're doing and that you don't work in silos. And I'm sure that this is the path for the future. And yeah, I think we've come to the end of the very stimulating 1 hour as far as I'm concerned. There's an awful lot of material here, but thank you so much everybody for listening, and let's see if we can minimize the mismatch. Thanks very much everyone. Good night.